with the approval of combination of atezolizumab plus bevacizumab, the role of TKIs is somewhat in flux because all the TKIs were FDA approved in an era where sorafenib was the established first-line treatment for patients with advanced HCC. So a lot of the FDA approvals for TKIs such as regorafenib or cabozantinib were done after patients had received treatment with sorafenib. So the inherent question is really, what do you do for a patient that is, let's say, initially treated now with atezolizumab plus bevacizumab? Should you go to oral TKIs such as sorafenib or lenvatinib, which were previously established as first-line treatments for advanced HCC, and essentially start that as essentially moving from your first line to now second line, and then your second line agents such as regorafenib and cabozantinib to third line? Or another school of thought is that you would essentially just jump to your second line agents, even though they haven't had sorafenib exposure, and essentially jump right away to regorafenib and cabozantinib. I think, I don't think there's a perfect answer for this. I think it really follows ultimately what you believe in the data. I would say, for agents such as regorafenib, the regorafenib study was really done in patients that can potentially tolerate sorafenib. So I would say for regorafenib, you probably still have to go through sorafenib before you can really get to that, regorafenib setting where you would use that agent. Cabozantinib is interesting because cabozantinib, all it had was that patients had to have some exposure to sorafenib from the Celestial trial. It also included patients that went on other treatments, including immunotherapy, prior to going on to cabozantinib. So there is some data about prior immunotherapy before going on cabozantinib. So I think it's not wrong to kind of skip ahead and go to cabozantinib as kind of a second line agent post atezolizumab plus bevacizumab. But I think at the end of the day, for our field in HCC, we probably need good retrospective analysis to at least tell us something about what is the efficacy of these agents post atezolizumab plus bevacizumab as we use this more and more. And I think it will be also good to look at some post ad hoc analysis of the EMBRAVE 150 trial in terms of those patients that got atezolizumab plus bevacizumab and what agents did they get after that and how were they able to respond to those agents to give us some clues in terms of what is the ideal sequencing of treatment moving forward.